Perfect.
I'm a dentist, and the dental board is absolutely rabid on this subject.
Nice.
Yeah.
That's great to hear.
I want to make certain that I'm in full compliance.
All right, good morning everyone on stream and here in the room. We'll be started with Salon H and PDMP breakout session shortly. So just hang out, grab a glass of water, bottle of water, juice. And all right, good morning everyone on stream and here in the room. We'll be started with Salon H and PDMP breakout session shortly. So just hang out, grab a glass of water, bottle of water, juice. And all right, good morning everyone on stream and here in the room. We'll be started with For everyone on the stream, we're currently redoing the rooms. We're going to be moving PDMP and the Maryland context ones over to Salon AB, and we'll be back here shortly. Podium's yours.
Okay. Okay. Hey, thank you everybody for coming to this presentation today. I think just like in the airlines, your gate has been moved to a different location, and it's not the most convenient thing in the world, but at least you didn't have to run from one end of the airport to the other. So that's a good thing, and I'm very happy and encouraged by the great turnout for people wanting to learn more about the Maryland Primary Care Program. I am Dr. Howard Haft, and I'm a country doctor turned executive director of the Maryland Primary Care Program. And before I start the presentation, I just wanted to introduce some of our team who is here today, people who will be working with the primary care program to help encourage practices to move through really challenging but important transformational programs. So in the back of the room, and they're already standing up, so I don't have to ask them to stand up, are our coaches. Lawrence Devadotson, Shante Gilmore, Takesha Elliott, Ruby Anderson, her husband Gerald Anderson, and Nico Salas. Nico's already there waving. He's the most eager person there is in the world. And Rachel Maxwell, who leads the team. So without further ado, because we're already a few minutes into the program, I just wanted to let you know what is in store for you for the next 40 minutes or so. I am going to go through fairly quickly at a high level a description of the Maryland Primary Care Program, and then turn it over to Will Daniel, who's also in the back of the room, is with CRISP, who will talk about a couple of the really important features that CRISP brings to this program. And I cannot overestimate how important CRISP is to this program. I know you all here as part of the CRISP user group are already sympathetic to that notion, but I can tell you categorically, were it not for Maryland having CRISP, the highest functioning health information exchange, innovative and thoughtful and integrated program, we would not be where we are today in terms of healthcare transformation in the state. So CRISP is an important, fundamental, and foundational piece of everything that we do, and it's particularly important for the Maryland Primary Care Program. So without them, we would not be where we are. But let me just kind of do a little level setting first. And first, it's important to understand that where the state is now is we're beginning in January 1st of 2019 to enter into a new total cost of care contract, which builds on the work that the hospital system has done over the last 5+ years in terms of shifting from fee-for-service to global budgets and then to population health. There's 3 important parts of that overall total cost of care model contract, and the Maryland Primary Care piece is one, but it's really in order to understand the big picture, you need to really understand how all of those things fit together. The first and big part in the leadership originally came from hospitals, where hospitals first moved to global budgets 5 years ago, and now we're further moving with this contract to an actual affirmation of being able to reduce the cost for healthcare, reduce the total cost of healthcare over a glide path of 5 to 10 years, while improving quality. And this is really the holy grail for all of us. We've been searching in this country for a decade or more now to solve that problem, to undo that Gordian knot. How can we actually produce improved quality while reducing the cost of care? And I think it's beginning to happen right here in Maryland, and Maryland is a leader. And our hospital colleagues have been really out in front in being able to lead that charge. But they recognized as we went through this transformation, that hospitals can't do that alone, that it needs to be done in conjunction with all parts of the healthcare delivery system. And the next most important, or the equally important foundational piece, is how to involve providers in that transformational process. So the new contract that came out said, yes, hospitals are taking a front seat in an important role, but right next to them in the front seat have to be providers. And there were a couple of elements that evolved out of that are one of which we're going to be talking about today, which is the Maryland Primary Care Program. I'll go in more detail about that, but it basically said, if we're going to transform healthcare and we're going to be able to reduce costs and improve quality, we need to connect the providers, and we have to start with the most populous of our specialties and the most foundational, which is primary care. So we put together in this model. Voluntary, and I emphasize the fact voluntary, providers can join it only if they want to, but highly beneficial program to all our primary care providers and said you can join up in this great initiative that Maryland's involved in. But it didn't stop just with the primary care providers. The contract also included abilities through what's called a Care Redesign Amendment for all providers to be able to enter into arrangements with hospitals and between themselves to produce shared savings, to continue to improve quality while lowering costs. And all of those programs, some which have been minted already and some which are still on the drawing board and are yet to emerge, all have the same basic foundational underpinnings. They need to show how they improve quality and how they lower cost. If they don't do those things, if they don't meet that test, they won't be acceptable. So all in all, we're harnessing and unleashing all of the innovative and creative juices of all of the providers in the state to say, let's all get on this train and do all these great things together. And then, to me, one of the most incredible pieces of this is that as part of this contract, our federal partners, the federal government through CMMI and CMS, has said to the state and to the governor that if the state can improve certain population health measures, that we will give you back credits which were equivalent to dollars against this total cost of care. Basically, not writing a check, but saying it'll come out of your total cost of care. You'll benefit from improving the overall quality of health for the state for big picture items, and not just for Medicare recipients, but for everyone in the state. And big picture items like diabetes prevalence. So in this state right now, there's about 10%, more or less, of the population of 6 million people who have diabetes. So 600,000 people who have diabetes. We know that's an enormous cost to those individuals. It's an enormous cost to the healthcare system because people who have diabetes have much higher risk for, besides directly the diabetes costs, the indirect costs that have to do with cardiovascular disease, kidney disease, and blindness, and other conditions that derive largely from diabetes. So the federal government is saying to us, if we can reduce the number of people who have diabetes going forward, we're going to give you credit against that. Basically real dollars that the state can use. And the way we do that is by addressing those people who are on the cusp of diabetes, the people who are pre-diabetic. And by some studies, that may be as much as 30% of the population. So you think about another 1.8 million people who will be moving into the ranks of having diabetes. If we can prevent that from happening or delay that from happening, it's a tremendous gain. But it doesn't just stop there. Every year under this contract, we can add additional measures like hepatitis C or opioid deaths or hypertension, things that affect everybody across the board in the state, and be able to focus all of the resources in the state, not just hospitals and not just primary care doctors and not just specialists, but all of the creative juices and the policy levers that the state has to be able to improve the overall health of the state. To me, that's how we tie all this together with a ribbon and say Maryland is open not only for business, but to be a healthier state overall. So that's my story on that, and I think it's a great story, and I'm just so excited to be on this train as it leaves the station. But I wanted to now talk about how we're working with a partnership with our federal partners, with both the state and our partners at the Center for Medicare and Medicaid Innovation in the Maryland Primary Care Program, which is a piece of this that I have primary responsibility for. So we've said that this is a joint program, that we're doing it together, and then over years the state will continue to take on more and more responsibility of this program, and ultimately it will become a state-run program as it finishes up its initial journey of 8 years. And it'll be the way we do business in the state in a permanent way. But right now, CMMI is responsible for the application process, for the selection of practices that will be in the program, that is those that have made it over the bar to be able to be selected to be in the program. And there's certain requirements in terms of minimum number of beneficiaries and other things, and I'm not going to go into detail here. selections of our care transformation organizations, and that for some of you may be a new term, and it is a new term overall in the world. We minted care transformation organizations here in Maryland. They don't exist any other place, and they're a fundamental part of this program, and I'll describe those in a little more detail later. But the federal government selects those. They provide a learning system. They provide all of the payments to the program, to the providers and to care transformation organizations come directly from Medicare, although the state is responsible for those payments so that they accrue to the total cost of care. So they pay, and we're responsible for making sure that we generate savings from those payments. And they provide data to practices on attribution and certain risk scores and the ongoing operations that we do jointly. What the state's role is we facilitate and support the entire program. So we work together with CMMI. We have been doing over the last several years, and we'll continue to do outreach to practices, to our primary care practices around the state, those who have been already applied, and those who haven't applied as we go forward because there's annual open enrollment periods. We'll continue to support the education of the practices and the care transformation organizations, and we do that in conjunction with our partners in the federal government and their learning system. We have also minted something new in the world, that is practice coaches or practice facilitators, call them what you like. They're going to be so critically important. Those are the people I introduced you to who are standing in the back of the room in the standing room only sections, and their job is this really, really important and critical work of, as we go through the process of transformation for our primary care practices, to be at the elbow, at the side of those practices and those providers, encouraging them and leading them to resources to make this process easier. Change is really tough. Change is a really tough thing to do. Even if you want to change, having organizational change is a challenge. And it's just really so important to have somebody there that's coaching and encouraging all the time. Even on top of webinars and all the great distance learning and other pieces that will happen within the learning system, to have somebody right there at your elbow to help you through the process. So I think they'll play a critical role. The state also, because we have this great organization called CRISP, will be providing a lot of additional, really relevant, important, timely, and easily actionable data at your fingertips, as you've heard about in the earlier presentation. But things that are specific to the program also, like claims data, and quality reporting data and utilization data, and tools that we'll be continuing to develop on risk stratification, so that our practices will be able to not only understand who's in front of them now, but understand who has not showed up yet and needs to be seen in the office because they are at great risk of falling into that ED or hospital bailiwick when they could that could be prevented with some easy interventions. And then annually we'll be convening our advisory committees and making suggestions about things that the state can take on serially over time. So just to highlight a couple of things that, as you may or may not know, the Maryland Primary Care Program was built on the chassis of a program that CMMI has had for the last several years nationally, and I think now 17 or 18 different markets with many thousands of practices, called the Comprehensive Primary Care Plus program. We built it on the chassis of that, but we made it a very specific Maryland program. And it differs from the CPC Plus program in a number of really critical ways. One is that it's a state program. It's not just a program that is one region, but it's one that's done in conjunction with the state, in conjunction with our state HIE, and it is unique in that way. But also the CPC Plus program has an enrollment period. If you get into that, you're in. If you don't get in, then you're not in the program. There's no subsequent open enrollment periods. Our intention is to have as many practices as are capable, eligible, and want to be in this program, in the program. So we've said, let's do an open enrollment every year. So knowing some practices might not get in the first year, or might want to sit back and wait to see what it looks like, is a very reasonable approach. we'll have open enrollments over a 5-year period. So practices will still have plenty of opportunity if they don't get in the first time to get in subsequent years. Also, in CPC Plus, practices are on one track or another. That's kind of an entry track that has lower requirements in terms of transformation, and a higher track that has higher requirements and some blended capitation and some other features that are much more robust in terms of healthcare transformation. We said, you know, we really want our practices, even if they start at a lower level, to move to the higher level, because we really see all of our practices that are in this program performing at the highest level possible. So all of our practices, even if they come into track 1, will move to track 2 by the end of the 3rd year in the program. So by the end of the program, we'll have nothing but the best primary care practices in the world here in Maryland. There won't be any track 1, just all track 2 practices. And I think in the other states, it was a multi-payer program. We are the only payer in our program to begin with is Medicare, but we're already having great conversations with the commercial payers and with colleagues at Medicaid and others to make this a real multi-payer program, and I think that will happen before the end of the program. So let me just go through now. That's kind of a bit of background stuff. What is transformation all about? What is it that we're really shooting for? So I'd like to put it into these 5 big buckets of care transformation and primary care functions, and these are the kind of the mom and apple pie pieces of what we see in any patient-centered medical home. And at a high level, I'm just going to go through these fairly quickly, so we'll have some time at the end for questions and answers. But they're about access and continuity, care management, comprehensiveness and coordination, beneficiary, caregiver experience, and planned care for health outcomes. Those are the keys, but let's just talk about what they are at a high level. The first one, and I think the foundation for building any kind of patient-centered medical home or advanced primary care, starts with this. It's impaneling patients to care teams. That is saying to a provider, do you know who your patients are? Who is the flock that you're tending here? And do your patients know who their provider and their care team that supports them are? That's job number 1. We need to make sure that people understand, and to a great extent, many of these practices already do this, but this has to be uniform across the board, that people understand, I know who my provider is, and I can get access to that provider, that I can do that 24 hours a day, 7 days a week. Even if they're not in the office, there's a direct connection I can make to somebody who knows about me if I'm a patient and cares about me and has my records. And of course, without CRISP, this would be a really difficult row to hoe, but with CRISP, it makes it a much easier row to hoe. And then also that we reshuffle the deck in terms of access to care. There was a time when it still exists to a great extent, when our primary care doctors are really getting burnt out and overworked and having to see 30 or 35 or sometimes 40 patients a day, which obviously doesn't leave sufficient time to really do a good job with anyone. We're saying, as far as this access, let's take a look at access in a broader concept and say, how can we provide appropriate access to people? So those people who need to get more care and more time, give them more care and more time. And those people who are basically healthy and just need a blood pressure check or something like that, let them phone it in. Or if they need to be seen, let them come in. And let's make sure that anybody who wants to be seen in the same day, who has a need, who's sick that day, that you have space for them in that day. So to have same-day appointments and next-day appointments and redo the schedule so that all those things can be accommodated in an appropriate order. And now with the technology that we have, we can do so much without having to see people face-to-face for things like blood pressure checks. When I was a country primary care doctor, often we would fill up the schedule with those simple things because, you needed to get a lot of simple things to leave enough time for the more complex kinds of problems. And see 10 people a day who just needed a blood pressure check. Well, I could have seen those 10 people. I didn't need to see those 10 people face to face. I could have had them send in their blood pressure readings from at home and had my nurse practitioner or medical assistant or someone else who is managing those processes let me know what was in good control and what wasn't, and decide, triage who needed to be seen and who didn't need to be seen in that way, and so leave more time for things that were more complex. So we're asking to do all of those things and be thoughtful. Every practice will do it in a different way because every practice serves a different population. And then there's care management. After you've decided who your patients are, let's start taking a look at deciding, again, in a detailed, in an analytic way, who has the greatest need and who doesn't. And those who have the greatest need, let's be able to define what their needs are specifically and give them the appropriate resources for those. So to be able to risk stratify patients in a variety of different ways and then link them up with both short and long-term care management programs so that they can have their needs met. This is something that has not happened to any great extent, and to me this is a fulfillment of a great dream if we can really get this done in a comprehensive way across the state, because so many of our patients, so many people that we care for, have needs that exceed what I, as a primary care provider, can give them directly, that they have needs that extend to what happens outside of the office space, that happens in the community, in the home, and need somebody to spend some more time with them dealing with the non-medical and social determinants or the coordination of their care with multiple specialists and all those things. And a single provider sitting in front of a patient can't do all those things, doesn't have the resources until we do this risk stratification and bring in actual care managers into the milieu and the fabric of care. And then there's comprehensiveness and coordination. This is another really important feature, is that very often we have patients who not only see a primary care doctor but see a lot of other doctors. And there's been a tremendous disconnect between the primary care doctors and the other doctors that patients may see. And this is particularly true for our Medicare fee-for-service beneficiaries who don't require any referrals and are free to go see whoever they want. And that's not a bad thing, but it should be something that's done in a coordinated effort so that the primary care doctors know who their patients are seeing and can do this really wonderful thing, which is creating co-management agreements in collaboration with those specialists so that there's no duplication of services. I can't tell you how many times as a primary care doctor, as an internist, I'd see a patient and order a big panel of lab tests, and I get those tests and I go, oh my God, the person needs to see a specialist because of some features in that. And they'd go to see the specialist the next week, and when they walked into the specialist's office, the first thing the specialist receptionist would say is, you need to first get your blood drawn because they won't see you until you get this comprehensive group of tests done. And they're the same comprehensive group of tests that I did last week, and they will differ not one iota from what they did, but there was no collaboration, no coordination of effort. That happens not only with blood tests, but it can happen with MRIs, it can happen with a whole host of other things. It can also happen in the tail end of that with duplication of medications. And I order a prescription for somebody and they see a specialist and they say, you need some new blood pressure medicine. And they didn't have any visibility on what they already had, and the patients may or may not bring that list with them that says what they have, and that can cause a tremendous amount of not only excess cost, but as a hazardous thing that can happen to patients. So this coordination effort is really, really important. Also coordination as we progress with community resources, so that not only the things that are happening with specialists, but 60% maybe of the things that are the determinants of health outcomes are not those things that are things that I'm directly in control of. It's really the non-medical or social determinants of health, things like housing and adequate nutrition and safe environments and transportation and on and on. So when we ignore those or we don't ask those questions, we're dealing with 40% of the patient's issues. We need to really begin to address those other non-social determinants, and that's part of what is embedded in this program, is to be able to ask those questions and then link individuals who have gaps in their social supports with those supports that exist in the community. So, and the next piece is this beneficiary and caregiver engagement. This is simply gathering your patients together and asking them in a time when they're not sitting naked or with a paper gown on them across from you and behind your computer, when you're in a more relaxed environment and they can be more open and probably more honest, ask the patients, tell us what we're doing right and what we're doing wrong and how we can improve the care that we're giving to you. So we're going to have all of the offices, practices doing at least a couple times a year these patient family advisory councils that will allow them to get a different view of, kind of the patient's perspective on things that can be done better in the delivery of care for those specific patients. That's part one of this. Part two is to make sure that we ask patients as providers what they want in terms of their advanced healthcare delivery wishes. What do they want? What do they see for their, not just their end of life, but all of those steps along the way? How do they want to be involved? How much do they want to be involved in the medical decision-making? Do they want to have all of the information or just some of it? Do they want us to act entirely paternalistic and just say what to do? Or would they, as most people, want to be involved in a conversation? So this is a new way of making it very patient-centered. And last and not least is planned care for health outcomes. This is using data to assure that we're continually improving what we're doing, and whether it's the care for patients with diabetes or hypertension or a whole host of other things, using data and doing analysis and doing these PDSA cycles and continually improving how we deliver care, both in the way we deliver it, but also those things that we deliver. And those are kind of the broad brushstroke elements. Within the program, we're going to be collecting some information. One of the interesting things about this program that I think differentiates it from others, and is part of the new wave of how we're looking at collecting measures, is that we just are now emerging from a period of time, if you've been in ACOs or other kinds of state and federal programs, where we've had maps and large lists of measures that have been collected, 17, 21 different things to report on for practices. I think we've come to the realization that if you're trying to report on 21 different things, that you're not going to be able to report on any of them very well, and that there's nothing like focus to bring success. So in our discussions both with our stakeholders and with the federal partners, we've come to the understanding we're going to really limit the number of required measures that are going to be reported. They'll be reported through CRISP, and that makes it much easier, and CRISP can automate that process significantly. But we're going to really focus on just three things in terms of the electronic quality measures, and that's going to be diabetes and hypertension control as outcome measures, and then substance abuse, initiation, the asking the questions and initiating treatment for substance abuse. Now, why would we stick that one in there? Well, I hope that's not an aha moment to anyone here, but we're in the midst of one of the worst crises that we've had in healthcare in many decades, and we're losing more than 2,000 people a year, and it looks like it's become a steady state crisis now. And we need to engage our primary care providers as well as all the other elements in the state in terms of being able to identify those individuals who are in the throes of substance abuse disorders and be able to direct them to treatment programs. So we're really serious about involving that also. And then some other things will be collected that'll be utilization data and the usual CAPS kind of data that the federal government usually collects. Utilization will be hospital and emergency department utilization, particularly on those fee-for-service beneficiaries. So that's really describes kind of the nuts and bolts of the program, and we'll have some time at the end for questions, which you might have. But I can tell you that that my impression is that our primary care doctors who've signed up for this, and they've signed up in enormous numbers. I think the applicants were 80% of all of the eligible primary care providers in the state. So I've never seen a program in my years that has been so enthusiastically applied for. And I think that it's not because of this. What I'm going to tell you about this is the financial incentives for joining the program. I think it's because at least to all of the providers that I've talked to, because they really want to do something different. They want to do something better. And if somebody just gave them some encouragement and some resources to do that, that they would just jump right on this train and get on it as it leaves the station. But there are, I think, appropriately balanced incentives, financial incentives for joining the program. And this really describes what those incentives are. There are really three different payment structures that come out of this. One is a care management fee. This is what allows the providers to hire care managers and do a lot of the transformational work that goes on. It's risk stratified, and it's a per beneficiary per month. So the more beneficiaries you have, the more you get. Also risk stratified along their what's called HCC scores, which means the sicker you are, the higher the payment. And the payments go from $6 up to $100 per beneficiary per month, which I don't know if anybody here has been in per beneficiary per month programs before, but that's a really high PBPM. That's reserved for the sickest of the patients. Those are in the top 10% in terms of risk scores, but also for patients who have substance use disorders, or patients who have dementia, or patients who have behavioral health disorders that are serious and ongoing, because they need more care management resources. And that's paid up front. One of the detractors from a lot of the programs we've seen in the past is that people do things and then they'll find out how they did a year later, and then they'll get paid 2 years later. That's really low on the incentive scale. In terms of behavioral economics, that ranks at about a -10 on a 1 to 10 scale. This is paid up front, and it's a generous amount. There's also a performance incentive that says the better you do in those aforementioned performance indicators, the more of this incentive you'll be able to keep. It's also paid upfront on an annual basis, so it's given this $2.50 to $4, depending on which track you're in, upfront for a year. And then depending on how you do for those measures, you can keep anywhere between none and all, but getting anywhere over 80% in terms of scoring will get you to keep all of the amount that's provided in that. And then between 50 and 80, there's a gradation. And then in individuals who are in practices that are in track 2, there's a 10% increase in their E&M codes. So instead of just getting whatever you would have gotten before, you get 10%. And then some portion of that is given based on what the practice, what portion of it they want to get up front as a kind of a capitation. We don't call it capitation, but it looks just like capitation. So a portion of the payments are made up front. So there's three streams of income, new streams of income that come to the practices, and they're generous. They're enough to get this done. But the important thing is not that they're enough to get this done, it's that our practices and our providers want to get this done because they know it's the right thing to do. And then we've added, as I said, to the mix, care transformation organizations. And this was something that came out of our learnings from stakeholders over the last several years, where our stakeholders on the federal side said, a lot of small and medium-sized practices had difficulty in meeting all of the transformation requirements in the program because they couldn't resource care managers or behavioral health integration or those kinds of things. But we, so they needed more resources, and they had to contract for them, and sometimes it was difficult to contract for those things. And our hospital and ACO partners said, we have a lot of resources here in the state already, so let's see if we can put those two thoughts together. And out of them came the care transformation organizations. And what they do is they provide resources to the small, medium-sized, or other practices that will allow them to meet the requirements of the program. What I didn't highlight previously, but I'll highlight now, is one of the key elements that's been missing in a lot of the ability of small and medium-sized practices to meet the requirements of the program was behavioral health integration. And that's kind of one of those things that's been difficult for practices all across the country to find adequate resources to do real behavioral health integration within the confines of a primary care practice. But it's an important thing to do because many of the issues that people come to a primary care practice for are either primarily behavioral health. They could be depression, anxiety, more serious mental illness, substance use disorders. but there's no resident resources in most practices. And the ability to refer to those very limited resources that exist outside of the practice are really very hamstrung and limited. And for that reason, practices often don't ask those questions, because you don't like to ask a question about substance use or depression unless you can do something about it. So oftentimes those things get ignored. Well, we're not going to let that happen here in Maryland and with these practices. We're going to address that. And so one of the things that I think our care transformation organizations will be doing is being able to resource those, find resources for the behavioral health integration. And it can happen in many different ways, and I'm not going to go into the details of that, but the important thing is that there will be real and evidence-based behavioral health integration in every one of our practices, starting from track one. And our care transformation organizations will be providing all of those resources to those practices who choose a care transformation organization. They don't need to do that, but if they do, what they do is they share some of their care management fees with them. So the CTOs will provide services that are integral to meeting the care transformation requirements, but don't require the personal professional services of a physician. So these are a lot like the CCM language that you may have seen before, the care coordination management language. Those services are provided under the the general supervision of the provider, so that they're not doing this on their own. They're doing it as part of basically as part of the team led by the main provider, the physician, nurse practitioner, whoever that is, who's leading that team. And it's designed to enhance the capacity of the practices. And they provide resources that are both embedded in the practice and those that can go out into the community and see people where they live, work, play, and pray, or in their hospitals, so that they're free to move about, which is also really critically important for care managers. So the program supports for the practice that we'll be providing in addition are a lot of information technology through CRISP, through the CMMI portal, through the care transformation tools, through the learning systems, and through the additional supports that I've mentioned previously that the state will be providing. There's some health information technology requirements for the practice. In order to be in the program, they need to utilize the certified electronic health records. It's the 2014 version as it is now, but that'll mature over time to 2015 and other versions as they become generally available. And this is important in this venue that we're here in now, is that there's a commitment to effectively use CRISP services and share data by the end of the first year in track two. And that there's a commitment for the practices to be using CRISP to even be in the program. So we don't have any practices that are not umbilically linked to CRISP and thereby umbilically linked to hospitals and to other providers. CRISP will serve a very critical role in terms of the quality, ECQM, quality measure reporting, because all of that reporting will come from the practices to CRISP, and CRISP will report it to the state. Our practice coaches, who I introduced you before, will be available to all the practices and to the care transformation organizations. And I envision them as sort of the glue that holds everything together. And they'll be promoting between and among the practices best practices as we go through the program. So at this point, I think I'm going to turn the podium over to my colleague, my very good friend, Will Daniel, who has been, I can't say enough good things about him. He's been integral in developing this program, both from the CMMI side and now with CRISP over many years. So, Will?
Great. Thank you, Dr.
You're welcome. And we'll have some time for questions and answers at the end, I hope.
Thank you, Dr. Heft. I want to talk about the requirement to use CRISP, the purpose behind that, and then what that means and what services are going to be provided by CRISP. I want to first say that while there is, I think, or will be in the participation agreement, a requirement to use CRISP by the practices, I don't know whether it's an umbilically required requirement or anything like that. So we'll talk about what that actually means. So this requirement to use a health information exchange is something that CMMI put in the CPC Plus programs because I think in their view of the world, practice transformation is those 5 care transformation areas that Dr. Haft talked about,
But if you think about how to do comprehensive care management, be the sort of, quote, quarterback of care for a beneficiary, it requires that you have a vision across the entire delivery system. In CPC Plus, CMMI said that in order to actually act as the quarterback, the practices are expected to use a health information exchange. Sort of unfortunately, when CMMI goes across the nation and goes into 16 or 17 different markets, there's no coordination. There's no single HIT that a practice can work with. And so CMMI sort of said, practices, you're supposed to be using this data to quarterback care, to build partnerships with hospitals and specialists. But in terms of actually building those relationships, you're on your own. So in Maryland, we have a fortunate opportunity to have the ability to enroll or at least get applicants from 80% of the practices, but also build a consistent infrastructure and a consistent method of engagement for all the practices. And so the purpose of sort of this requirement and the services that Chris will provide to the MDPCP practices are this exchange and availability of clinically relevant information. So each practice is going to get a list of beneficiaries that they're required to do care management for, that they're attributed to under the MDPCP program. And the idea is to track those beneficiaries, to see where they're getting their care, to coordinate it where appropriate. So CRISP is going to be providing a couple of different things. The most important, I think, is actionable data on those beneficiaries. So if you're being paid on reducing utilization for ED and inpatient stay, you really need to know whether you're succeeding or not, and you need to know, who your patients are, where they're getting their care, whether they have a chronic condition, et cetera, et cetera. And so the vision of this is to provide, a snapshot into what the patient panel actually looks like, the utilization metrics, and so on and so forth. The second, I think, important aspect that CRISP is going to provide is sort of assistance with the quality-based reporting, which is an important requirement of the MDPCP program, but also one that, when it comes to quality reporting, folks sometimes need as much assistance as they can get in terms of, getting those information submitted to CMS. So CRISP will do that. And then thirdly is promoting effective treatment planning and monitoring of health outcomes. CRISP has ENS notifications. This is intended to say, your patient has been admitted to a hospital, discharged or transferred from the hospital. That, I think, as a minimum, is a necessary criteria for managing patients and watching them throughout the continuum of care. So the notification services, the panel submission, I think, are going to be an important part of the package that CRISP makes available for practices to help them manage care. So I don't know if you want to come back up, Dr. Haft, and help answer questions. Or
Do we have time for questions?
We have 2 minutes.
All right.
Very in-depth question.
Any? Yes, so for practices that have decided on a voluntary basis to join a CTO, there'll be a CTO practice arrangement document in which the CTO will define which services, depending on which option and which track, and we won't get too far down into the weeds with that, they are providing. They will provide the same services, the same group of services to any practice that they have contracted with, and the practices will be able to indicate which of those services they wish to access.
Will that automatically provide the authority to access their patient's information?
There will be what's called a BAA, or a business associate agreement, that practices and the CTOs will have, so it will permit the access of information. Yes, sir.
Creating behavior, though, is that are we or have like a care coordination agreement with the behavioral health physician to work closely with them?
You just hit, well, I don't know if you heard the question, but the question is, if we integrate behavioral health, do we hire someone to come into the practice? Do we train someone in the practice, or do we coordinate the care with someone outside of the practice? Yes, yes, and yes. So that, I think it's, there are many different routes to that. They'll be better defined as we look at the go forward in the practices in terms of the implementation guides and those things. But the collaborative care model is one of those methods, and I think that kind of defines broadly how behavioral health can be integrated. But there needs to be, the most important thing is needs to be a very tight and evidence-based exchange of information between the primary care providers and the behavioral health providers. Yes, sir.
On the same question, in our area we are pretty low on behavioral health professionals, and the health department does an awful lot of work in that area. Are you engaging the local county health departments to be part of it?
So the county health departments are engaged, and I think many of them are eager to do so. I can't predict exactly how those resources will be used. I think that we're going to be building that bicycle as we ride it. So it's, I think it's going to be interesting to see that. But your point about behavioral health resources being scarce, I think, is true across the state. There's no place in the state where there's really overwhelming numbers of resources that. So we're going to have to be very creative and innovative in how we get those resources together. But we will do it. Let me go toward the back. Yes, sir.
Thank you. Continuing about behavioral health, Maryland has very restrictive laws about information sharing, particularly around substance abuse, and they seem to be getting tighter instead of looser. So this program is asking us to integrate and share information, but the state and our attorneys are saying that we're not allowed to share a lot of that information, and they're creating extra firewalls around mental health and substance abuse. Are you talking with anyone in the legislature about breaking down some of those walls?
So I think you raise a very good point, and I think there is some caveats to that, in that certainly there's no large firewall between providers, particularly providers that are co-located in the same office sharing behavioral health information. There are some settings and circumstances where it becomes more difficult, but behavioral health integration breaks down a great deal of that barrier. But to your very good point, I think there are some artificial barriers between sharing information that need to be addressed. And I know that our colleagues, not just here in Maryland, but across the nation, are working to do that. That needs to be done not at the state, but at the federal level. Maybe time for 2 more questions?
Two quick questions. There's a lot of providers that need access to methadone treatment.
Yes.
Because, that's not available at this time. So I want to know whether there's any barriers to make that information available to primary care physicians who might be prescribing medications like benzodiazepines or other medications that may increase the risk of overdose for that patients. Mm-hmm. The other one is that there are patients that receive substance use disorder treatment that are legally mandated for that treatment. So there's a certain utilization of resources dictated by the legal system. So how do you plan to address those issues?
So I'm not sure I can address the interface with the forensic behavioral health world. That's a little past my area of expertise. But in terms of the medication-assisted treatment, we are working with the state, developing resources both to develop integration of what's called SBIRT, screening and brief intervention and referral to treatment, to those practices that want to get it. So we'll have people who can help integrate that into workflows. And we've worked with our colleagues at SAMHSA, the federal government, to develop free medication MAT waivered programs across the state that will be done in a more easily digestible version than what is now. So easily done, more easily done, and without cost. So I think we're on that. And the forensic part I can't answer. So one more question. Okay, go ahead. In the back.
Will, how does the MDPCP attribution methodology work? And does it align with the attribution methodology under the
So attribution is always a bit complicated. It does align somewhat with the MPA, or I would say rather the MPA aligns somewhat with it, rather than the vice versa. And it's done. The simple thing is that it's designed to attribute patients who actually do get their care from a practice by virtue of them having received an annual wellness visit or a CCM, chronic care management visit, or the plurality of visits to a particular practice. Attributes the patients in that way, first and foremost. So it's based on as close as you can get to a real attribution. It's done prospectively. So I think we're probably at the end of the time. I thank everybody for coming and look forward to your participation in the program.
Hey there. I have a jump
Your
drive.
presentation is the Care Redesign, correct?
Yeah.
All right, for everyone who's looking for the Care Redesign panel, it will be here shortly. Yes, so if you're waiting for the Care Redesign, it was track 2 in room AB. Sit tight, it'll start in like a minute. We need to make sure Lindsay's got a presentation. What's that? We need to make sure Lindsay has a presentation.
When does the session end?
You can take a little bit of time since yours.
I think we have lunch after, right?
So you can order.
So it's basically 50 minutes. Okay. If you're going to be joining us for the Care Redesign session, I welcome you to move up if you would like. We'll be doing a live demonstration, so if you want to be able to see some of the details on the screen, it might be easier if you're a bit closer. We'll be starting in just a minute.
All right, for everyone who's still trickling in, we have the Care Redesign Program, Track 2, starting in here in 30 seconds.
I am, yes.
So the features you were talking about in the support Maryland PCP,
Yes.
are they in place now? Like the quality elements and that slide that you showed that had like the bullets?
So they're not in place now. They will be in place very shortly.
Okay.
So, okay, I think we're going to get started with the Care Redesign program conversation. So for those who were in the last presentation, my name is Will Daniel again. For those who left, I was watching, and we'll talk about that later. People just wanted to see Howard, I guess. I'm presenting with Audrey Speeder, who's my colleague from H-Metrics and does a lot of the data analytics and program support for the Care Redesign program. So, oh, you can't hear me. Hello, is this any better? How is this? Can you wave if you can hear me in the back? Oh, wonderful. Okay. So during this presentation, we're going to talk about two things. The first is an overview of the Care Redesign programs, what their purpose is, how they fit into the Maryland total cost of care model, and then what CRISP's role in supporting and administering the Care Redesign programs vis-a-vis the state of Maryland, the HSCRC, and the hospitals. And then second, we're going to talk about the data analytics that CRISP provides to participants in the Care Redesign programs, and we're going to go through a couple of use cases to show that off, and at that point I'm going to turn it over to Audrey to do all those. So at a high level, the Care Redesign program is one of three sort of programs in the Maryland total cost of care model. So the model is basically structured to say there's a hospital payment program, that's the global budgets, the GBR that's administered by HSCRC. There's the Maryland primary care program that Howard was just up talking about that's managed by Behm. And then there's the Care Redesign programs that are also managed by the HSCRC, but are structured to include additional participants. So the global budgets are obviously a hospital payment system. They do not include physicians. One of the comments that both the state and CMS received very early on in the Maryland all-payer model was that hospitals need to build alignment with physicians in order to actually change and improve care for beneficiaries. And while you had, sort of an incentive structure and alternative payment arrangement for hospitals under the global budget, those global budgets were just for hospital payments, and it created a mismatch in terms of financial alignment and financial incentives between the hospitals and the physicians. So the Care Redesign program is designed to allow hospitals to create more of an incentive for physicians and non-hospital participants, SNFs, et cetera, to participate in Care Redesign and participate in the Maryland all-payer model. So the particular financial incentives are incentive payments to what we call care partners. Care partner is just any Medicare provider that's not a hospital that signs up to participate in one of these programs. And an incentive payment is just a cash payment that is made to a care partner that is intended to incentivize what we call care redesign interventions. And so these interventions are not, they shouldn't really be a shock to anyone, but it could be performing medication reconciliation for beneficiaries, it could be filling out care plans, it can be more operationally oriented, filling out discharge orders by 10 a.m., something like that. The Care Redesign program has 3 tracks underneath it. There's a hospital HCIP. This is a program that works with hospitalists who are operating in the hospital. There's the CCIP program. These are primary care doctors and others that are out in the community, so not necessarily a hospitalist. And then there's ECIP that is intended to create incentives around the post-acute episodes. So I'm going to briefly talk through each one of these programs, and then happy to answer any questions you guys have about that very briefly. So the community care program, this is a program that was designed by HSCRC to target very high-risk beneficiaries that are in need of care management out in the community and aren't receiving it. So this was modeled around the CCM requirements that came out. So you can sort of think about what the intervention is designed to increase the uptake of CCM. This program was also sort of thought as like a MD-PCP, so a primary care program light. When it was first, when we first talking about this with CMS, the Maryland primary care program was still a twinkle in Howard's eye and other people's eyes. And we wanted to increase uptake in these sorts of activities as sort of a glide path or a transition to sort of the full primary care program. And so CCIP, was put in place to do the same sort of activities that are required under CCM and MD-PCP. HCIP is designed to increase care coordination, medication reconciliation, other efficiency measures with hospitalists that are operating in a hospital in order to try and make a hospitalization stay more efficient. And then ECIP is modeled on CMMI's bundled payment program, so the BPCI and BPCIA programs. And this program is designed to basically hold a hospital accountable for what happens post-discharge and create some incentives for the hospital to manage the post-discharge episode of care. And this involves, increasing sort of utilization of home health services and also developing clinical partnerships with SNFs and other post-acute care providers. And, in BPCI, we saw a variety of hospitals deploying different interventions, such as sending docs or nurses to round with their patients at SNFs or forming sort of collaborative care arrangements with home health agencies. So I want to talk very briefly about CRISP's role in the Care Redesign program. The program is created by HSCRC, and sort of at the end of the day, they are the ones that make the policy and design choices about it. So they're the ones that created all 3 of these Care Redesign tracks. These 3 tracks are not the only tracks. Tracks can be added and removed. The HSCRC makes the decision about whether to remove them. I don't see Chris Peterson in the back of the room, but I can point him out if you have suggestions for new tracks to add. The reason why I mention that is that while the Care Redesign program allows participation from any non-hospital Medicare provider, each of those 3 tracks have a different set of providers that they're intended to build an intervention with. That set is not comprehensive, and there may need to be additional tracks that are added in the future to include different provider types and different interventions that are not covered under the existing program tracks. So HSCRC sort of makes these design decisions, and then CRISP helps with administering them. So I'll give you an example. With the ECIP program, each hospital is given a target price for their post-acute episode of care. They're at least hopefully expected to bring post-acute care costs under that target price. If they succeed, they get a reconciliation payment as a reward. There's no downside risk. CRISP is the one, and H-metrics are the ones that calculate the target price. So our role in the process is going to be to both help HSCRC with the technical calculations, but then also help the hospitals and the participants in the program succeed. So one of the things that CRISP will do is provide data and analytics to participants in the Care Redesign program so that you actually know who are in your episodes, where the costs come from, et cetera, et cetera. So all of the data that we provide is based on what's called the Medicare CCLF data. This is the claims line feed. This is the same data that CMS uses for its ACO programs, for its other value-based programs. This allows a huge degree of granularity. We basically see every service that a beneficiary receives that Medicare pays for, with some exceptions around SAMHSA and so on and so forth. That data is basically ingested into CRISP, and it's provided in a series of reports that are designed to help hospitals succeed under the program that we're going to talk about in a moment. So what we're going to do now is talk about ECIP and how those CRISP reports are designed to help hospitals that participate in ECIP. We chose ECIP as an example for this. The data is provided to any participant in any CRP track. There are reports that are helpful for CCIP and HCIP, but we chose ECIP because the implementation protocols for participants are due today, and that program is going to go live on January 1, 2019. So we wanted to provide an example that would be sort of immediately useful for you guys. So just a quick recap of what ECIP is. There are 23 clinical episodes, such as joint replacements, stroke, AMI. In each one of those episodes, when a patient is discharged from, or Medicare beneficiary is discharged from the hospital, it triggers an episode. That episode goes for 90 days post-discharge, and we calculate how much costs, Medicare costs, that beneficiary incurs during the 90-day post-discharge. There's a target price that's based on the historical costs for each hospital, and the hospital can earn an additional incentive payment if their costs fall below that target price. So if your target price is $10,000, the actual post-acute care costs are $8,000, that's good, and the hospital will receive an incentive payment. The hospital can then share that incentive payment with any of the care partners that they sign up, and these can be physicians, SNFs, home health agencies, et cetera, et cetera. So the hospital can choose to make some of that available to their clinical partners in managing that episode of care. Okay. So I'm now going to turn it over to Audrey, who's going to go through a couple of use cases that are hopefully helpful for participants in the UCIP episode.
Wonderful. Thank you, Will. Okay, good morning, everybody. So as Will alluded to, we are going to be focusing on ECIP this morning, but I want to introduce you to our MAID suite. So our MAID and our CCLF suites are often used synonymously. They're referring to the same reporting portal. You guys hear me better? Yeah. Okay, excellent. They're referring to the same reporting portal where you can have access to patient-level information to really understand every care transition and every instance that your patients have with the healthcare system. So to start, I want to introduce you to the goals of MAID. So our MAID tool has 3 primary goals. First and foremost, it's to provide insight where you can focus your care redesign and your care coordination efforts. So looking at your population as a whole, where is there opportunity for you? Where do you really need to focus your care redesign and care coordination? From there, you're able to monitor your population and your patient-level trends. So taking your population as a whole, if you're thinking about your ECIP population, it would be patients that have touched your hospital for a given DRG family or specific DRG. You're able to look at their trends over time. look at their readmissions, their utilization, their overall spending, with the overall goal, as Will said, to stay below that target price, to manage their post-acute care. And the third goal is to facilitate the use of making those opportunities actionable. Once you've understood where your care redesign and care coordination opportunities exist, actually managing that care and looking at the patterns of care and making them more streamlined so you're able to reduce that overall utilization and meet your benchmarks. So to start, for data source and access, as Will mentioned, the MAID data is sourced by the Medicare Claim Line Feed, the CCLF data. This is an amazing database. This gives us really the most granularity in data that we could really ask for. It is a monthly file that is provided to hospitals and CRISP. We operate generally, the reports that we have available have about a 3 to 4 month lag in them. All of the claims presented are complete, so you're really able to see virtually as up to the minute as you can, given that we're working with claims data here. The population for the data are the Medicare fee-for-service beneficiaries only, which is totally appropriate for our ECIP and all of our care redesign tracks. You're only going to see those beneficiaries with Medicare fee-for-service coverage. And as Will said, the data is hosted and processed by H-Metrics for CRISP, and we want to make sure that those reporting suites are most useful for you. So in order to get access, I imagine many of you probably have access to the suite right now. There are 2 different credentialing levels. You have a PHI level and a non-PHI. Your PHI level is going to let you get down to the individual patient. You're going to be able to see every instance that they have or every touch with the healthcare system, be able to get down to medications received, lab result or lab tests ordered. And if you have the non-PHI access, you'll be limited to your summary or your aggregate reporting. Still very helpful to look at overall trends. You just won't be able to drill down and look at the individual use cases or the individual patient cases. And your POCs will be able to get you access for all of that if you don't have it already. So to get started, MAID is a web-based interface. It's accessible through any of your modern browsers. And when you log into your CRS portal at the reports.crisphealth.org, you'll see this card, the CCLF Medicare Analytics Data Engine. Click on that and it'll get you right into the system. Okay, so before we get into a live demo, I want to give you kind of a quick overview of what we identify as some major use cases for this. I'm going to be showing you ECIP specific examples, but the data and the reports really transcend all care redesign efforts. So we'd like you to think of it more as care coordination, care management, and population health. So with that, we have 3 common use cases. First is our executive or population health manager. We picture this as an individual within your organization that wants to look at overall program and population trends. You want to look at your readmission rates over time. You want to look at overall how your per member per month spending for your population has changed. These are kind of the big picture assessments of how your programs are doing. So we think that's super, super critical, and you need to kind of have that holistic population health view. The second use case is our financial use case. Very important from an ECIP perspective is what is the opportunity for savings? What is the total cost of care? How does it compare to benchmarks that you're going to be held to in order to get reconciliation payments? So it's very much your financial analysts, your CFOs, looking at your overall population. And last, our most granular would be our clinical use case. This is where you're able to get down and dirty with care management. Looking at individual patients, looking at their patterns of care, indicating if you see a pattern of care for an individual patient, is there an opportunity for intervention? Is there an opportunity to talk with their primary care physician or talk with discharge planners at the hospital to see if there's some opportunity to streamline that care? So what we have on the right here, let me get my laser pointer. Oops. 1 second. Okay. So what we have on the right here is a matrix that crosswalks how the use cases link to the modules. So we have 4 modules in MAID. We're going to be focusing on one of them today, but I'll give you a quick summary of all of them. Our population module is going to be your most granular level. This is where you're going to get your patient level detail. This is where you're also able to identify rosters of patients, meaning you can define a population of interest and you can use that roster to review all of your other reports across the MAID suite. So it's really good from kind of a population health view. Second, we have our episode module. This is looking at the touches to your system and then the 90 days of care that follow, looking at all of the post-acute care here. The pharmacy module and the monitoring module is really quite amazing to us. We have in the CCLF data all Medicare A, B, and D claims. So we're able to use a lot of that information in the pharmacy module. So you're able to look at trends in utilization for your medications, for your populations, look at brand versus generic distribution, look at high-risk medications, who's prescribed them and who's taking them, to give you a good sense of where there's opportunity to one, streamline care, avoid adverse events, and potentially reduce total cost of care. And last is our monitoring module. This is really kind of a holistic look at overall trends over 12 to 36 months. How has your total cost of care in terms of per member per month, readmission, ER admissions, all changed for your population? So this matrix gives you a quick indicator of what we find to be most important for any given use case. It would be very easy to have every check mark on every cell here. But we tried to drill it down to what we find to be really the root cause. From an executive perspective, from your first column, we find all modules to have that high-level executive population health report view. So you'll find in any one of those modules reports that'll meet your needs. In the second column, in our financial, you'd focus primarily on episodes, pharmacy, and monitoring, staying away from the population level, the population module, because the individual patient is not going to indicate to you opportunity. You'd want to look across a population for that. And third, we have our clinical, where we're focusing primarily in the population module. That's where you get the really good aggregate information. Okay, so now we're going to do a quasi-live demonstration, and we're going to be focusing on ECIP. So MAID right now is not designed with the ECIP episode perfectly in sync. MAID was designed to address population health and care coordination, most specific to CCIP or other care redesign efforts. H-Metrics and CRISP are working together to develop an ECIP-specific suite that basically mirrors MAID. So with that said, I will be showing you information that has your index hospitalization and readmissions included in your total episode costs. When we look at an ECIP-specific model, those costs would be removed to align with the program definitions. But in the interim, until that information is out, we think this will be a really helpful resource for you. And just my quick disclaimer, everything you're going to see here is using demo data. So you're going to see patient names, you're going to see what looks to be patient identifiable information. It is all fictitious. We have protected all PHI here. Okay, so our first use case is a post-acute provider network evaluation. Our mindset going into this is that if I were to be an ECIP participant, I need to manage my total cost of care. How do I manage my total cost of care over a 90-day episode? I need to make sure I'm working with the right providers. I need to make sure that every time I refer to a Sniff, I'm using the best Sniff that's going to meet my needs. They're going to keep my cost down, they're going to keep my readmission down, they're going to keep my patients safe. They're going to ultimately get them into the community as soon as possible. So there's some tools here that are going to make sure, by looking through the charts and looking through the patterns, make sure you have the right providers in your network. So we're going to look at the impact of the first pack setting of making sure, how do I determine what that first step is for my patient? Where should I look? Where should I discharge my patient to? Thinking about general trends, not looking at an individual patient level, and what the implications are if I refer to SNFs in general compared to home health compared to directly to the community. We'll be able to compare pack providers, and we'll be able to do provider level details. One second. There you go. Okay. So this is the MAID screen. I can tell that some of these numbers are going to be a little hard for you to review. Excuse me. There you go. I will be using my laser pointer to help point out. I will remind everybody that the Genius bar outside, my colleague Daniel Rosenzweig will be manning that, can show you all of this again. We'll also make these slides available. So I hope you can bear with us, and we'll address any questions afterwards. So this is our MAID home screen. As soon as you click on that blue card to get you into the CCLF MAID interface, you're going to end up at this screen. On the top, you're going to see the 4 modules that we reviewed. These are your quick links to get you into those modules and to get you exploring. If you look to the right, you're going to see your hospital name identified. If you are credentialed for more than one hospital, there's a drop down here and you'll have access to every hospital that you are credentialed to have access to. If you are working within a system, you would be able to then change this hospital indicator from hospital name to hospital system. It'll aggregate all of your patient data. You can look at your system as a whole. And last, we have an attribution method embedded into MAID at this point. We are currently looking at an inpatient touch attribution. So any patient that has touched your hospital with an inpatient admission over the last 36 months, you have access to right now. This is perfect from an ECIP perspective because you'll only want to be looking at the patients that have entered your hospital for hospitalizations. There are revisions down the line to get MPA attribution in here. So not necessarily for an ECIP perspective, but we're working to get MPA attribution so you can see those beneficiaries as well. And then this is basically a table of contents of every report that that you'll have access to. Okay, so jumping in, let's talk a bit more about our episode module. Our episode module is a 90-day episode of care following discharge from your hospital. So you will only see patients that have left your hospital for an inpatient stay. We are including in all of our payments our index hospitalization costs and readmissions, as well as all other Part A and B costs. From an ECIP perspective, that readmission cost does not need to be in there. You're not held to that in your target price, but it is incredibly important from a care coordination and care management perspective. So I will mention readmissions many times in the next few minutes. And I think the focus is you need to understand what the implications are for the patterns of care and for the post-acute care of your patient while you're not held to it from a financial perspective. Okay. So, sorry guys, this is getting a little... Okay, so it might be hard to see, but we're going to get... My apologies, the visualization. There we go, okay. I might lose my laser pointer. So when you first move into the episode, the first thing we're going to do is get into the episode module, and I want to draw your attention to the first PAC payment report. This is a report that provides me a high-level summary with what's going on in my organization. So when patients are leaving my hospital, where do they go? And we find this incredibly important when you're looking at what the implications are for total episode payment. So you'll see your first PAC setting. I'm going to risk this again. 1 second. Okay. You're going to see your first PAC settings here, and you're going to see the distribution of your episodes going to those first PAC settings. So I see right away that I have about a quarter of my patients going to a skilled nursing facility. I have about half of my patients leaving the hospital going to an ambulatory care setting, and it's important for me to understand that distribution across all my DRGs. What's most important is when you look at the average episode payment for episodes that leave my hospital and go to a skilled nursing facility, they are incredibly more expensive than the patients that leave my hospital and are able to enter the community directly. We recognize, my disclaimer for the day, we recognize the clinical appropriateness of all of these various care settings, and we are not suggesting that a patient needs to go somewhere due to the financial implications of it. But what we are asking everyone to reconsider is let's find the best setting for that patient. And you just have to understand what the implications are from a financial perspective. So as we look at the bottom of this table, this is a visual to help you understand the real distribution of your patients. So in the blue, we're looking at the number of episodes. So you'll see blue is the number of episodes, and then orange here is your average episode payment. So you'll see this very top line here, where my mouse is the inpatient rehab center, inpatient rehab facility. Very small proportion of your episodes are going here. But when you look at the average episode payment, they're incredibly expensive. Likewise, your readmissions are actually quite small. There's a small amount of patients leaving the hospital and getting readmitted before they have any other care in the system. Incredibly expensive. What we have found as a general rule is that if a patient has a readmission anywhere in their 90-day episode, their total episode payment is about twice as much as a beneficiary who did not have a readmission. It is not the cost of the readmission itself that's driving that. It's restarting the cycle of the post-acute care. So they might have gone from hospital to a Sniff to get readmitted. When they leave that readmission, they may go back to the Sniff, and you're getting hit with two facility-based post-acute care settings. So as we, I want to get a little more specific here, and I'm going to make this DRG specific. So from an ECIP perspective, in my use case, I'm interested in hip replacements. I'm interested in my orthopedic procedures. I know that many of them are elective. I know there's an opportunity to manage that care and get the patients into the right setting. So by using the drop downs at the top here, you're able to select any of your ECIP DRG families and specific DRGs and see your distributions of care. So this is where things get a little interesting. I have about 44%, almost half of my patients who are leaving my hospital for a hip replacement, leaving to go to a Sniff. And I know from current literature that there's a lot of trends to get patients after hip replacements into the community, into outpatient therapy. Maybe there's an opportunity for me to readdress some of that. But we have a large percent going to Sniffs and having very high episode payments. Whereas if the patients were to go to home health or into the community, you can see just by the bars without even seeing the numbers, they have a lower episode payment. That's going to make it more likely for me to be able to reach my target rate for my specific DRG of interest. So our next step here is I'm going to come from the perspective that for a patient that I am interested in, Sniff use is appropriate. My patient needs to go to the Sniff for various reasons. It could be socio-demographic reasons, it could have been clinical reasons, but I know in my head as a discharge planner, I'm going to get my patient into a Sniff. My next step is making sure I get them to the right Sniff. All Sniffs are not created equal. You want to make sure you have your network fine-tuned and really, really serving you in the best way for ECIP. So the next report we're going to look at, this is not happy with me today. There you go. The next report we're going to look at is our skilled nursing facility report. This is a report that allows you to look across SNFs. So again, I already have in my head my patient's going to a SNF. Let's get them to the right one. So numbers aside, the colors here are very meaningful. You see on the top bar that we are looking at length of stay. The middle section here, we're looking at average episode payment, and below that, when I scroll, you'll be able to see readmission rates. These are your top providers, so you're going to have your most frequently referred SNF providers on the left side, getting less frequent on the right. So let's talk about color here. Anything in blue is above the average for the SNFs that you are referring to. Anything in orange is below the average. So without even looking at numbers and lines, I can see several SNF providers that have higher length of stay, higher average episode payment, and later we'll look at readmission, whereas there's several providers that have lower measures in all of those categories. So what I'm drawing attention to is this third provider, relatively high frequency, it's towards the left side of my chart, higher length of stay, higher episode payment. And as we scroll down, I'm going to be looking at a readmission chart. And even further, I have all of this information in a tabular form so you're able to digest it from a little bit of a different perspective. Excuse me. So again, I have interest in this third provider. They have higher readmissions. I'm referring to them a lot. I want to make sure that they really should be in my network. So by looking at the bottom table, you're able to see their distribution. They have, I believe, 13 episodes within my DRG. I am within 301 still for a hip replacement. And I have my average episode payment and my post-discharge payment. My post-discharge episode payment is effectively everything minus the index. So it is that 90 days of care. So we have the functionality built in here that if I have this provider in interest, I'm able to hover over them. You'll see a pop-up for post-discharge provider details, and I can get a drill down report to understand everything about this specific provider. So again, this is keeping me within my 301. What's nice here is all of your DRG functions persist across your reports. And this tells me right away that I have 13 episodes. 4 of them had readmissions. They have a readmission rate of about 31%. That could be somewhat alarming to me. If I'm referring to them as my third largest Sniff, readmission of 31%, it's above the average, could be concerning. And I do see that when I have that readmission, the average episode payment is almost twice as much as when I do not have a readmission. So there are significant financial implications there. So as we scroll down, I'm then able to also see which physicians referred to this Sniff. So if I did want to intervene on any of my referral patterns, if I did want to narrow my network, and I might have considered that this is not the best provider for me in my ECIP enrollment, I would be able to identify the physicians that are referring to those providers, talk to them about their choices, ask them why are they referring, why did they choose this Sniff. There might be very compelling reasons. We have to recognize beneficiary choice here, and we are not undermining any of that. But in terms of developing a network that works best for you, kind of enabling you with data to have those discussions with your physicians. The next one, there you go. As we scroll down a little bit more, I get even more information about this. So what you can see, kind of barely, what you can see in this column is a sequence of care. This is where we're getting down to patient level information. I told you above that we have 13 episodes or 13 patients discharged to the Sniff. There's 13 rows of data there. And this tells me where a patient goes after they leave the Sniff. So it's not just enough for me to know they had the hospital, they went to the Sniff. Where did they go after? Did they get readmitted? Did they go to the ER? Did they go to the community? So what you'd want to pay attention to is instances where you see an ASA. So they had the acute care hospital, they went to the Sniff, they then had a readmission or another acute care stay. It's just helpful to understand the patients that are going there and what their patterns of care are. What happens to patients once they leave this setting? Okay, so our next step is I want to show you just briefly the home health report and the inpatient rehabilitation report. We won't spend as much time there. They are identical in form and function. The only difference for the home health one is that we do not have a length of stay indicator. Rather, we have a number of visits indicator. So it's the number of skilled home health visits during their 60-day home health episode. But you're able to easily identify the relationship between the number of visits, total episode cost, and readmissions. So this first home health agency might be a good example. They have high visits, high cost, ooh, I just skipped there, but they have low readmissions. This might be a wonderful provider that I want to keep in my network. So we're not indicating that you need to have the trifecta of everything perfect to be in. You need to really drill down, and the MAID tool will provide you with the details so you're able to do so. Next on the, and then we still have that detail at a provider level for the home health. The home health agencies, you're able to see your referring physicians, you're able to see the detail on the home health agencies, and then access the provider detail with the patient level sequence. Getting into the inpatient rehab. Inpatient rehab is a really interesting setting. They do amazing work. They are generally low utilized benefit within the Medicare fee-for-service space within Medicare, we have found. We find that they're generally much more expensive than all the other post-acute care settings, but they provide much more intensive rehab, and there's absolutely a clinical case for them. So you'll find your utilization to generally be fairly low here. Their costs are generally high, but it's important to make sure you have the right ones in your system. Okay, so with our next step is I'm going to kind of change hats a little bit and say, now I know when I'm using a Sniff. Oh, there you go. I want to make sure I have the right Sniff in my network. Everything I have showed you so far has not been risk adjusted. We are working within a single DRG. We recognize differences in severity of illness, but we haven't accounted for that in the data that we've shown you so far. These are effectively their reported metrics. So what we have created under the monitoring tab, so I've switched into monitoring now, is our Sniff utilization report. And this is an attempt to get all Sniffs on the same playing field. Let's risk adjust so that our readmission rates are comparable, our length of stay is comparable, and our Sniff payments are comparable. Not comparable in value, but comparable in the patient population that they represent. So this is in tabular form. What you'll first see is this is every single Sniff that your facility has referred to at least once. So this is going to be a very significantly long list. There are no DRG filters. This is just a much more global look at the Sniffs in your system. So what I want to pay attention to is, in terms of risk adjustment, we're going to start with readmissions. So we use what's referred to as a PCR algorithm. It is the planned all-cause readmission rate. It is an algorithm developed by HEDIS, which is the system under the Agency for Research and Health Quality. And it allows us to adjust reported readmission rates for the clinical diagnoses and comorbidities of a patient population. So I can look at Sniff A, I can look at all the patients that they've seen, look at their demographics, and effectively come up with an expected readmission rate. I can do the same for Sniff B. I can then adjust those two numbers to say if I know the differences in the clinical and the expected readmission rate, let's adjust it. So what we have here is our overall total, and then in color-coded, which is a little bit faint on your screen, but in color-coding down this column, you will see numbers in varying shades of green or red. If a facility is green, they are lower than your overall average once you risk adjust and have everybody on the same playing field. If they are red, they're going to be higher than your average readmission, again, taking into account patient clinical severity. We use the same methodology when we're looking at length of stay. We risk adjust length of stay in this column, and we risk adjust the average Sniff payment. Rather than a PCR expected readmission rate, we do it based on the RUG score, so basically the intensity of services provided in the Sniff. So we find this to be a really helpful tool internally to say, okay, now once I put everybody on the same page, how do my Sniffs compare? And in combination with the patterns that you've seen on the previous reports, this can help you kind of really refine your network. Last point on this is you'll see that we're looking at a masked report. If I click through here, you will have, you'll see in this column a lot of cell suppression where it says less than 11 cells. We have suppressed all PHI in this report. This could be printed and handed to a Sniff for a discussion. You don't have to worry about PHI identification. There is an unmasked version if you want to be able to look internally with other colleagues appropriate for PHI, where you can see individual cell counts. Okay, so let's switch gears and look to use case number 2. We are identifying and prioritizing ECIP opportunity. So in my first instance, I just wanted to make sure I had the right people in my network. I don't know what to do with them, but I know if I want them in my network or not. This use case is coming from the perspective of, I'm interested in ECIP, I'm interested in having an episode-based post-acute management, but I have no idea where to start. I don't know where my low-hanging fruit is in my organization or where I can have opportunity, most attainable opportunity so I can reduce my total cost of care. So in this use case, we're going to look at our low-hanging fruit, we're going to compare our physician discharge patterns, and we'll look at some physician-level details. All right, so to get started, we are back in our episode module, and I have clicked here on our opportunity summary. So our opportunity summary is a predictive model developed by H-Metrics that effectively looks at patterns of care from a physician perspective. Where is the first setting that my physicians are referring patients? What is the resulting total cost of care? And what happens if I streamline that? So if I have physicians acting in very numerous different ways, what if I got them to all kind of work in the same direction or have similar patterns? What are the opportunities for the healthcare system? And I'll walk you through that when we see a little more detail on this. So the first thing you'll see on the top is this is not DRG specific. This is only available for an entire hospital. But I see here that this hospital, this is a very large hospital, has $49 million in opportunity. What this means is this is not saying this is guaranteed savings. This is giving you a level of opportunity of if you were to change your discharge patterns out of your hospital into your post-acute care settings, what is the bread box that you're working with potential opportunity? Also, this is not hospital-specific savings. This is across the entire healthcare system. So if I'm wearing my same hat as before, I'm still interested in my hip replacement, or I don't really know where I want to be, but I want to see where hip replacement falls into this. As I start perusing down here, I'll see my DRG 301. I think it has about $2.3 million in opportunity. If I were to click on this DRG, you'll see all other columns immediately filter. So I have $2.3 million in opportunity. I know which physicians are responsible for that. I know which post-acute settings are responsible for that opportunity. And then you have service line, which would be expected as orthopedics for this case. So I'm able to see I have one provider that's responsible for a lot of my opportunity. We're going to keep that in mind in a minute. But I want to get more information here. So by hovering over this, you can access an opportunity details report. And this will make a little more sense when I'm talking about physician clusters. So before we get overwhelmed by all the lines, let's pay attention to the top here. This is an overall summary. This is basically telling me that of the total episode payment that I have for 90 days for DRG 301, 30% of it is potential opportunity for savings. Just by changing my first discharge setting, I could save potentially $2.3 million for the healthcare system. So now let's look at colors. So I want you to kind of ignore numbers for a second. The bottom, your x-axis are represented as individual physicians that are discharging patients for a hip replacement. If you look in cluster 1, you're going to see a good amount of green, which is home health. You're going to see a little bit of orange, which is Sniffs. You're going to have a small smattering of blue, which is your short-term acute care hospitals. Predominantly, you see more green. If you look into your second cluster is here, you have a bit more of an even distribution. Bit more home health. You have an even distribution of Sniff, home health, and ambulatory care and readmissions. But if you look at the right side, your third cluster, it's almost all orange, indicating skilled nursing facility. What this model is effectively doing is if you were to work with these physicians and change their discharge patterns to align more closely, actually it's number 3 and 2, align more closely with number 1, that's where your savings opportunity is coming from. So we're in a DRG. So we're saying within a DRG, the referral patterns should not be so significantly different. There's clinical reason for why they could be in some instances, and we're not going there. But as a general whole, there should be some consistency. And this pie chart on the top right is telling me on average, this should be my distribution of first discharge settings. SNFs are represented there. They definitely have a spot. Home health certainly has a spot. Ambulatory care of physician has a spot. And in some instances, you're going to have readmissions, and they're unavoidable, and that's okay. That's all represented in what we consider the optimal cluster here. And as we scroll down, just to show you the rest of the chart, this is just showing us, to kind of make it a little more clear, by cluster, what the average episode payments are. So you'll see the average episode payment for cluster 3. You see a really faint line right about here. This is the average episode for 3. It's higher than the average episode for 2. It's higher than the average episode for 1. Just indicating how the discharge pattern has an impact on episode spending. Okay, so from here, if our system works. I want to get us back up to physician discharge spending. So now I know there's differences in my physicians. Great, I know this now. But what do they really mean? So we have a report called our physician discharge report, and you'll see what the system is doing right now. The first thing it had to do is it had to get me into my DRG again. This is the one instance where it didn't know I was looking at 301. You got to go ahead and use the drop-downs. But what this is showing me is at a physician level, we're back to our colors of above and below the average. For your physicians on your x-axis, what is their distribution of spending? So our first is our average episode spending. So you have anything in blue is going to be above the overall average, anything in orange is below the overall average for all of your physicians in 301. In this bottom panel, your bottom panel is showing you your distribution of what your actual distribution is of your PAC spending. So something that's going to keep my attention is I have this third provider, incredibly high cost relative to the average. And when I look at their spending, they have significant Sniff use relative to the others. They have a lot more orange compared to everyone else, and they have higher spending. So what I'm able to do is scroll down on this table and get a bit more information about that individual provider. We're going to call her Dr. Claudia. And if I look at this third line, when you can see the full report, you'll see that she has about 50% or 60% Sniff discharges. She discharges to Sniff 60% of the time, whereas her colleagues under the same DRG are discharging to Sniffs closer to 10 to 15 to 20% of the time. As a result, she uses really low home health. She has about 6% use in home health. Everyone else is closer to about 20% of home health. So there might be an opportunity here of having conversations with Dr. Claudia, understanding what's driving her decisions. They might be social factors, that there's no caregiver at home and a patient needs to go to a Sniff. Totally appropriate. This is just arming you with information to enable those discussions to see if there's opportunities for streamlining care. So we are now able to drill down onto Dr. Claudia to get more information to see if some of my hypotheses are right about the complexity of patient. And these are physician-specific dashboards. So this whole page is specific to Claudia. You see the distribution of her episode payment. So for her average payment, she has about $58,000 in spending, what the distribution is by spending. And you're able to see the distribution of her first PAC setting. So I'm able to verify from here, yes, she has much higher Sniff use than her comparison. So she's on the left side. The right side here is all physicians in aggregate. So it gives you an immediate comparison of how she compares to everybody else. And then if we scroll a little bit more, we're able to then see the individual patients that she has treated. We do not have them identified by name, but we have their sequence here. So what's really interesting here is you'll see a sequence here of A and C. Those are patients that left the hospital and went to the community. I have a severity of illness here of 2. So these are moderate severity patients, left the hospital, were able to go to the community under her care. But there are also several individuals here that left the hospital with a severity level of 2, went to a Sniff, and then had ER admissions and readmissions and other care. So just understanding how there may be an inconsistency in practice patterns here, again, caveating clinical appropriateness. So just helping you understand the types of patients that are under the care of Dr. Claudia when they are leaving the hospital. Okay, so with that, let's just recap where we've been. We went through a lot of information. With the MAID tool right now, there are opportunities to see ECIP helpful information, while the reporting suite is not tailored specifically to ECIP. So you can focus on the readmission and the importance of those readmissions in your episodes of care. You can look at narrowing your referral network. You can also look at identifying the opportunity for your hospital. So we hope over the next few months, we're working through an ECIP-specific portal, which will get you really into ECIP-specific space and be able to give you a lot more information to kind of arm you with that. So with that, I think they told us to run long, which I think we've done. Just a few minutes. If there's any questions for Will and I, we'll be happy to address them now. Yeah?
2 real obvious questions. First of all, is percent of utilization of all of your facilities if your yielded SNFs are fully occupied and moving. And then the second obvious one is Dr. Claudia may not be as good a doctor once you do risk adjustment. How do you look into those things?
So we don't. You can. So we want to make sure to provide the information that you have everything you need about patients that they're treating, their referral patterns, and their resulting episodes to arm you to have discussions with them. There may be instances where some of the physicians are just not as good physicians, and those would be internal hospital decisions of how to address that. Whether it be kind of discussions or getting discharge planners involved with them at the point of discharge to help them funnel the patients into the right setting.
The other side of that coin, if you talk to Dr. Claudia, she's probably not going to be like, oh yeah, I'm not as good a doctor. So more frequently it's going to be like, my patients are more complicated. I have more patients with socioeconomic needs, et cetera, et cetera. We don't provide any of that information as well, and we're not trying to, right? That's sort of how do you handle your physicians and your patients, so on and so forth. All that medical stuff.
And then two other obvious follow-ons. Many years ago, some of our physicians had a proprietary interest in some of the nursing homes, so we would see they were always going.
What do you do about it?
Yeah.
Do you want?
So,
I can take it from a data perspective.
Sure.
From a data perspective, we recognize that there are referral patterns that are going to be innate into your organization. But by looking at those Sniff reports where we're adjusting for all of that, there could be an opportunity to kind of guide those decisions. But certainly from an incentive perspective or ownership or otherwise, we stay out of that. But Will?
So, we have, ECIP is designed to help the state succeed under the total cost of care model. The total cost of care model has saving targets. That means that someone in the state gets paid less, and now we're talking about who can manage patients better. ECIP allows you to share some of those savings, so you can have a conversation with the doctor. You might be losing some revenue because of your PFS payments, but here's some incentive payment to, help move in the direction of care redesign. But those conversations are going to be hard, and fortunately, we don't have to have them. You do. So, sorry. You had
When you're talking about episodes, say somebody is discharged from the hospital and they are readmitted for something completely unrelated, does that count, or are they balanced? Would it generate a new episode? Say they have an MI and then a couple of months later they break a leg falling down the stairs. It has really nothing to do with it. Would it be a different episode, or would it count to the admission?
So in ECIP, the acute care costs are not going to be included, including the readmissions. So that sort of example, right? That being said, the post-acute care episode is sort of the post-acute care cost, right. And so you can have sort of costs that are accumulated in the episode that are not sort of attributable to your episode. Those costs are included. They're not going to be big acute care costs, but they also will be reflected in your target price, right? So this is sort of like statistical variation that if you put it in the baseline, you put it in the performance period, it should average out.
But you will see that all reflected in MAID. So there are no filtering done on planned or unplanned readmissions, so you're able to see what really happened.
Okay.
So given the very significant impact of behavioral health secondary diagnoses on these medical DRGs, can you stratify within a DRG people with mental health or substance use conditions versus not, and then look at things that were done to those two different groups that may vary in expenses?
So there are a few limitations for that. For the behavioral health or substance abuse conditions that are covered under SAMHSA, we do not have those claims at all. So we're not able to identify which patients or what admissions are for substance abuse. We just don't have them. We're not suppressing them from you. We got them. But in our population module, we do have chronic conditions that you can lay on top of other conditions. So we would be able to say, like if you're looking at dementia, for example, or Alzheimer's, some of those that are not suppressed, you would be able to pull up in your ECIP suite once it's available, show me everybody that had a hip replacement, but also has a diagnosis for Alzheimer or dementia. And you would be able to then filter that population, store it as a roster, run all of your reports on that, and compare it to the population that does not have those chronic conditions.
But for, say, the group of depressed diabetics who are admitted for diabetes problems, you're not going to be able to have any insight into that?
Your depressed diabetics, we will have. Depression is not restricted from SAMHSA, but if they do have if they have a substance abuse issue, we will not. Mm-hmm.
Has there been any discussion, or maybe it's already in there and I just haven't found it, to layer in sort of non-CCLF data sets? So I'm thinking like quality, so like physician complications or nursing home compare quality data, to layer that into the matrix.
So what's interesting, which I didn't point out, on the Sniff readmission report, we do have their star rating. So we do have that there just for that single report. We would love to be able to get social determinants of health in there, but those are data sets that we do not have access to. So we're limited to the claims data by function of CMS giving it to us every month. We are interested in working with hospitals as appropriate. If you would like to give us polls from your EHR and able to get some of that information, kind of embedding for you kind of a custom suite that allows you to pull that information. But at this point, we are limited strictly to claims.
Filters, for example, on the SNF side, for avoidable care versus, you said it's planned and unplanned, it's for your 90 days, you're looking at total cost. Are there any thoughts, is there anywhere within the tool where we're thinking about being able to limit down the avoidable care, potentially avoidable care?
So, direct answer is no, but indirect answer is yes. We have a risk score built in. So H-Metrics has developed the H-Metrics Advanced Model, affectionately known as HAM, which is a predictive model of what is the likelihood of that patient exceeding a utilization threshold in the next year with impactable cost. So our threshold is $50,000. So it's what is the likelihood of of any given patient having more than $50,000 of impactable cost next year. Impactable cost we define fairly straightforward. If you have ESRD and you're receiving dialysis treatments, or if you have cancer or chemotherapy treatments, those are not impactable. No amount of care management from our perspective is going to reduce those costs. But if you have CHF and COPD, there is an opportunity for chronic management to help that. So you will see in your population navigator, it might be a hidden column, it's not default as shown, for a HAM score, and that's a 0 to 1 indicator. That will give you a sense of high risk from an impactable level. If you stop by the Genius Bar, I'd be happy to show you that. It's a little bit hard to conceptualize, but it makes more sense when you see that. Mm-hmm.
Do you have a...
Yeah, there's a question back.
Yeah, question about the monitoring tool, and they display the outcomes by Sniff. Are you able to then drill into patient level detail?
Not from that report. We kept that as an aggregate report of just saying, let's look at the overall SNFs and risk adjust that way. When you get into the Sniff reports, as I showed you, you can see a de-identified patient information, but we do not have an identified list of by name the patients that are distributed.
And it doesn't roll up to all of the Sniff facilities that are in the monitoring report?
It doesn't link to that. So the challenge with the monitoring report is that's across all DRGs, and you can also filter the age range that applies to, the data range that applies to. So the systems are a little bit different, that they don't link as nicely in that respect. But you should be able to look at that Sniff report that shows you the aggregates of the SNFs. And we can certainly go through that at Genius Bar as well. All right, we're keeping you guys from lunch. Are there any other questions? All right. Thank you, everyone. Hey.
So quick note for the afternoon sessions, we'll be back in normal rooms. So if you were in AB, you'll be in AB, and then H will be back in here. So after lunch, you'll have in-context data delivery with Mike Banfield. And for everyone watching on stream, we will be back at 12:30 for our third breakout session here in Salon H, which is the in-context data delivery, incorporating CRISP into your EHR. That will be with the Point Solutions team and Mike Banfield.